Hello, welcome to a CAPES or Clinician and Patient Education series known as Understanding and Managing Pain and Fatigue in Spondyloarthritis and Psoriatic Arthritis. My name is Philip Mease. I'm a rheumatologist based in Seattle, Washington, and I'm pleased to be moderating this program today. This is brought to you by several organizations that are noted in the bottom of this slide. Spartan, which is a spondyloarthritis-focused clinician education and research association based in the United States. GRAPPA, Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, which is focused on psoriatic arthritis and psoriasis, and is a group of over 1,000 internationally located dermatologists and rheumatologists. And then two patient service organizations, the Spondylitis Association of America and the National Psoriasis Foundation, both based in the United States. This program this evening is part of a series that we're conducting. Previously, we focused in on pediatric psoriatic arthritis and spondyloarthritis. And this program today will be followed by two other programs. One that's focused on the newer treatments that are emerging for the treatment of psoriatic arthritis and spondyloarthritis, and one that's going to be focused on wellness and lifestyle, which I think will be quite interesting to you as patients with this condition. This is all being made possible by an unrestricted grant from Pfizer. Here is our agenda for today's program. After this intro, we'll proceed into a presentation that I will be giving on pain, the neurobiology of pain, how it's assessed, something about its treatment. And then shifting to Professor Choy, who joins us from Wales, where he is chair in the Department of Rheumatology at Cardiff. And he has been a long-term researcher of the problem of fatigue, as well as pain and inflammatory arthritis condition. And then we're going to have two patients share their stories with us. Minionette, or Minnie Wilson, who comes to us from North Carolina, and Melissa Leeolou, who, although raised in New York, is currently living and a medical student at Stanford in California. They have had longstanding psoriasis, psoriatic arthritis, and in Minnie's case, significant spondylitis as part of her overall condition. They'll be sharing some about their experience, but also participating with Ernest and I in a panel at the end in which we'll be entertaining questions from you. And we encourage you to put your questions into the appropriate place on your panel there for placing questions, as well as just having a general discussion. So let's plunge into talking about pain first. This is a cartoon that comes from the 1600s when René Descartes and others were really profoundly capable scientists at the time who had already well understood much about human anatomy, in this case, neuroanatomy. And we're showing here someone who's putting their foot near a flame and experiencing that as a painful experience based on the sending of a signal through wiring, if you will, in the nervous system to the brain, where it's translated as pain, and then that gets the body to go through an action of withdrawing the foot from the flame. All of this happening in literally microseconds. We now have a much more sophisticated idea of the neurologic system in the body and realize how complex it is. So not only is there the basic wiring of the neurons that are transmitting signals from the exterior into the brain, but also from the brain to the periphery, and all of the things that we do, thinking and cognition, our motor movements, our sensation, all of this is being managed in these microsecond transmissions of signals through the neurons. And this is influenced by a number of different elements, including, for example, what our psychosocial and health status is, our focus or attention on the sensation that we're experiencing. It's very changeable. It can be influenced by changes in gene expression and all kinds of factors that change things. Pathologic input, meaning what if you have a disease that affects the nerves, such as diabetes, or what if you have a autoimmune inflammatory disease? All of these things will end up influencing the nervous system. Here is a somewhat simplistic view where we're showing you that on the lower right, there are peripheral nociceptors, as they're called, these sensory fibers that detect noxious signals, in the case of the flame, for example. This sends a signal through the dorsal horn of the spinal cord and up the spinal cord via these neurons, which are like telephone wires, only instead of electricity going through them, it's through certain neurotransmitters that are being expressed in the neurons and being released from one neuron to another. And they have names like NMDA glutamate, substance P, nitric oxide, which are transmitting noxious stimuli, and the brain perceives these up in the insula prefrontal cortex and immediately recognizes this as pain. Meanwhile, there is a descending pathway that's noted in red, which has a modifying effect. It helps to inhibit this being perceived as just a humongous problem, and it helps keep the sensory input sort of in a tempered fashion by inputting various neurotransmitters to the ascending pathway, such as norepinephrine, serotonin, something called GABA, and then endogenous opioids, as well as endorphins, cannabinoids, and so forth. So this is a finely balanced system. And what we're going to learn later on is that when you have a chronic autoimmune inflammatory disease or chronic painful condition, there becomes an imbalance in these two pathways, with too much of the noxious ascending side and too little of the descending side. We also now know that there are many, many neurochemicals and receptors in these nerve bodies that are transmitting information. And here is a list of just a few of them. And these are, as it turns out, going to be potentially targets for the pharmaceutical industry to go for in terms of developing newer and newer pain medications that don't have some of the negative aspects of the narcotic opioid pain medications. As we go more centrally, we now see the influence of glial cells, which are important cells that moderate the signaling that's going on up into the central nervous system. Pain is the primary complaint of virtually all rheumatologic diseases. And here's a listing of some of them, and you will recognize the ones that you have as patients: rheumatoid arthritis, psoriatic arthritis, spondyloarthritis, lupus, and so forth, but also more mechanical issues like neck and low back pain from osteoarthritis, regional pain syndromes, and fibromyalgia, which we're going to get into more in a moment. We know that when we do exercises in which we're trying to identify what are the key elements of a condition like psoriatic arthritis, we of course are assessing in clinical trials of diseases, of new treatments for the disease, the musculoskeletal disease activity, the skin disease, physical function, and so on. But pain is a central item that must be assessed in each clinical trial when we're developing a medication for treatment of the disease. And it's considered very important by patients. And this is amplified by a study that we conducted in 3 different cities with patient-focused groups led by a medical anthropologist. And of course, arthritis, which means partly pain, but also pain itself, are ranked high by both clinicians as well as patients as being an important aspect of their disease state, with fatigue ranked just after that. And then if we turn to the spondyloarthritis condition, which is, if you will, a cousin of psoriatic arthritis, but predominantly affecting the spine and not with skin disease such as psoriasis typically, we also see here that a mandatory domain to be assessed in all clinical trials of treatments for this condition is pain. So thus denoting that it's an important item. However, here is a survey that was done as part of the American College of Rheumatology Pain Management Task Force, in which they found that many rheumatologists are uncomfortable focusing on pain as part of their treatment. In medical school, most were not taught how to evaluate or manage pain, and most approach pain by concentrating on what is it that I can do to control the inflammation of, say, psoriatic arthritis or axial spondyloarthritis, but not so much about specifically focusing on pain itself. And are there additional things besides trying to reduce the overall inflammation of the disease in order to manage pain in our patients? Are there ways that are not harmful, like I consider use of opioids to be harmful? What are non-harmful ways or new medications that are emerging, or techniques such as acupuncture that can be brought to bear to try to treat the pain that a patient is experiencing? There are a number of ways that we assess pain, the simplest being just to ask the patient on a scale of, say, 0 to 10 or 0 to 100, how would you rank your pain today? Now, the patient may say, well, you mean pain where? Do you mean pain in my worst joint or pain in my back? Or do you mean, and are we talking about pain just right now that we're sitting here, or over the last 24 hours or over the last week? So these are all questions that need to be clarified by the clinician. And then the patient rates where their pain is. And that goes into the equation that the clinician is thinking about are we adequately treating the condition in front of us? A numeric rating scale is another way where you just on a 0 to 5 or 0 to 10 scale rate the degree of pain. And then what are the anchors? Is it no pain at all? Is it the worst pain you can ever imagine, like passing a kidney stone? These are some of the aspects of assessment. I just alluded to the time span of assessment being important, worst versus average pain. And then in some clinical trials, we use what are called composite measures, where we try to get at different aspects of pain by asking multiple questions that all bear on pain, such as the brief pain inventory or the PROMIS pain interference and intensity scales. Here's an example of a table from a presentation I recently did on a new drug that is being developed for psoriatic arthritis called brepocitinib. It doesn't really matter what the drug is, because virtually every trial that we've ever done with any of the treatments that you're on, whether it's one of the TNF inhibitors like Humira or one of the IL-17 inhibitors like Cosentyx, there's always this kind of table where we see what the disease severity is at baseline of the patients that are in the trial. And here we see on the row that has to do with pain that patients rank themselves around just shy of 60 on a scale of 100. So pretty significant pain on average. And as you can see in this trial, it was pretty well balanced between the different arms of the trial that were being, of the dosages of medication that were being studied versus placebo. And then this is a typical outcome set of graphs where we are showing the improvement in pain at various time points, week 16, week 52. We're also showing with the FACIT-F score there, improvement in fatigue. So it's important that we be documenting what kind of improvements are occurring as we're using or testing new drugs. Here's another one. This is a drug known as ixekizumab or Taltz, which is an interleukin-17 inhibitor used to treat both psoriatic arthritis as well as psoriasis and axial spondyloarthritis. And here you're seeing different measures of pain, joint pain, spine pain at night, and so forth, and showing improvements showing better improvements with the drug than with placebo. So those are typical kind of data that we show in clinical trials and show that we are improving pain. But that's a very sort of blunt way of assessing. And here is a more sophisticated methodology that is where we're having growing interest in. This is known as mediation analysis, where we're looking now at the drug tofacitinib, also known as Xeljanz, and it's from one of its trials in psoriatic arthritis. And we're asking the question, does this drug only work on improving pain by decreasing inflammation as measured by the CRP, which is a blood measure of inflammation, the swollen joint count, which is if you will, a measure of inflammation in the joints. And what was found, interestingly, was that only about 25% of the improvement in pain was through the control or improvement of CRP and swollen joint count. 3/4 of the reduction in pain was by other pathways, raising the question, well, maybe tofacitinib is having a direct effect on those neural pathways that I was just speaking about a moment ago, which is actually kind of novel, that maybe these drugs are not just controlling the inflammation, but also doing other things to try to improve pain. And one of the other fascinating aspects of this work that we've been doing with this drug is that it appears that some of the effect is through itch pathways. And so in patients with psoriasis who are bothered by itch, maybe that is also a neural pathway by which we can control pain. This leads to potentially new hypotheses about development of new medications that can work in these pathways. Now, I'd like to take the final part of these comments to introduce to you this concept of central sensitization or nosoplastic pain. And there are several terms that we're going to be using here. I've already mentioned two of them. Two others are the word fibromyalgia and then a phrase chronic widespread pain. These are all terminology that have to do with centrally mediated or centrally experienced pain that's different than the peripheral inflammatory pain that's being generated by inflammation in joints, for example. So here we have an older study done by Rick Raisley when he was at the University of Michigan, and it shows us that when you give a stimulus like pressing with a device on a finger, we call it the thumb smasher, and the investigator can put different amounts of pressure on the thumb. And here we're showing that over on the left-hand side of this graph in the upper left, we're showing that in that gray square, a relatively low stimulus intensity of about 2 kilograms per centimeter squared. And the patient who is a normal individual is experiencing a relatively low level of pain intensity. Then if you give a much higher amount of pressure, going up to let's say 4, almost 4.5 on that dotted line, that normal individual is experiencing much more pain, and it's showing up in the brain in these functional magnetic resonance imaging as a painful stimulus. But then take a patient with fibromyalgia, just with a low level of stimulus, they're experiencing a high level of pain intensity, and they're lighting up in the brain in the proper places. So they really are experiencing that pain. So there's something different about their neurophysiology that makes them much more sensitive to this particular pain stimulus. Here's another experiment where we're looking again at MRI scanning of the brain, and we're showing that even without an external stimulus, patients with fibromyalgia have a kind of turned on chronic signaling through these neural networks in the brain, as if their brain is on all the time, and that this contributes to their pain experience as well. Now, we know that there are lots of reasons that some individuals in the population tend to have more pain sensitivity than others. Down at the bottom, there are a bunch of genes that are there, listed there, and we know that if there's a certain genetic profile in an individual, they're more likely later on in life to develop this increased pain sensitivity. We also know that there can be many factors in their upbringing. They're perhaps had emotional distress during childhood, if they have a tendency toward depression or anxiety, if they have problematic autoimmune ongoing disease, for example, or a chronic pain state. This can all lead into an increased proclivity to fibromyalgia. Here we have a table that shows the fact that in patients with different kinds of autoimmune diseases, somewhere between 15 and 30% will have evidence of concomitant fibromyalgia along with their rheumatic disease. There are various ways we assess for this, including in clinical and in research studies, these various questionnaires that are given to patients. We're now doing this as part of a large registry study that we're doing with psoriatic arthritis. And there are also more objective ways like quantitative sensory testing or the MRI imaging that I showed you earlier. What difference does this make? Well, here we have a study that was done in Israel in which a total of 73 patients were assessed. And the investigators thought that 60 of these were PsA patients who did not have fibromyalgia, and 13 of them who did, which yields a percentage of 18%, right on with what we were discussing earlier. And if you look at some of the measures of disease activity in these patients, you'll see that with some of these measures that have acronyms like CPDI or DAPSA, are about twice as severe in the patient group that has fibromyalgia as compared to the patient group that doesn't. Now, there are a few measures that are more objective, if you will, like the blood test CRP, an inflammation marker, where there's really no difference between the two groups. The skin score, which is more objectively defined, our swollen joint count, they were about the same. So really, their true inflammatory biologic disease activity was about the same, but there was an amplification because of the in the patients with FM in those measures that had subjective elements, like how much pain do you have, or how much tenderness do you have in your joints. The one other point to be made here is that if we look at this line called MDA, this is achievement of a target of treatment called minimal disease activity, where everything has gone quiet after effective treatment. And we see that nearly half of the patients without fibromyalgia were able to achieve this particular criteria state, whereas none of the patients with fibromyalgia. Again, partly because many of the items that are in the minimal disease activity criteria are more subjective. So even though objectively the patient may have gotten to a good place, they didn't get there subjectively. Here is a similar kind of study in patients with ankylosing spondylitis done in Brazil, where again we see that patients with fibromyalgia, again representing about 15-16% of this population, had twice as severe disease activity measures as those without. And again, much of this is based on subjective answers to questions. Here is my last little study to show to you. And this is a study done in France in which patients were with axial spondyloarthritis were being started on a TNF inhibitor. And we expected to do a pretty good job in controlling disease. And here we're dividing the patients into those that were considered to have fibromyalgia, who were 31% of this particular population, and those that did not. And we find that if we're trying to get to a state of low disease activity, which is this thing called the ASDAS, less than or equal to 2.1, or remission of less than or equal to 1.3, we see that many more patients who didn't have fibromyalgia were able to achieve these thresholds as those that did. But one of the other fascinating things that I find in this study is that at baseline, whereas 31% of the patients were considered to have fibro, at the 3-month mark, 18% did. So it's as if effective treatment of their underlying axial spondyloarthritis, in this case, lowered the likelihood that their central nervous system was firing up this increased pain sensitivity. So it appeared that at least here, there was the ability of the immunomodulatory medication to modulate their fibro experience. Now let's talk just a moment about treatment. So here I have listed all of the various therapies that many of you know about for psoriatic arthritis, starting with anti-inflammatory medicines like the over-the-counter ibuprofen or Aleve, corticosteroids, which we don't like to use too much in PsA, and then the various immune moderating medications like methotrexate, and then the biologics that we come to know and really are very effective, like the TNF inhibitors that are listed here. These are all their generic names. You know them as Enbrel, Remicade, Humira, the Symphony or Cimzia. There's ustekinumab or Stelara here. There's secukinumab or Cosentyx, ixekizumab or Taltz. There's guselkumab also, or brisenizumab, known as Tremfya, and Skyrizi. There's abatacept, but there's also Otezla here, Opremilast, and the various JAK inhibitors. All of these medications are very effective at reducing the inflammation of the condition and in treating pain, as I showed you earlier, via their ability to control inflammation. But there are a lot of, and many of the same drugs, I would say, are used for axial spondyloarthritis with some exceptions. But there are also a number of different approaches that don't use medications. And I've listed many of those on the left-hand side. Cognitive behavioral therapy, conditioning exercise, physical therapy and massage, acupuncture, biofeedback, and others. These are used for management of pain as well as fatigue in our diseases. And then there are some medications that are specific for the phenomenon of fibromyalgia or central sensitization, including, for example, medicines that were originally developed as antidepressants. Duloxetine or Cymbalta is an example of that. Anticonvulsants, an example of that is pregabalin or gabapentin. Some of these you'll recognize because you may have tried them. Your doctor may have used them to try as a non-narcotic way of treating pain. And there are many, many other medications on the way that are currently in development at pharmaceutical companies, now that we know more and more about the specifics of the neurologic pathways that we're targeting. So in summary, we've been focused on learning that pain is a cardinal feature of rheumatic disease. impacting function and quality of life. The neurobiology of pain is complex and involves genes and environment and sociocultural factors. Pain assessment is important, and theoretically you're doing it each time you go in to visit your clinician. Concomitant fibromyalgia or nociplastic pain and central sensitization influence the way in which you experience your pain, and treatment should be targeted to whatever your main complaints are, but using not only anti-inflammatory and immunomodulatory treatments, but also non-medication approaches as well. So with that, I'll wrap up my comments, and I would like to, what I'll be doing is stopping sharing slides, and Professor Choy from Wales will be sharing his slides next.
Thank you, Phil, for that introduction. So I'm going to share my slide. Okay, so I hope all of you can see my slides. If you have problem, please flag it up and we'll try to resolve the technical issue. So after that wonderful presentation by Phil, it's my task to discuss with you about fatigue in inflammatory arthritis. And I think the first thing to say is much of what I will be talking about is probably relevant for all types of inflammatory arthritis. It doesn't matter whether it's rheumatoid arthritis, psoriatic arthritis, or ankylosing spondylitis. So what I will try to address in the next 20 minutes or so is to explain how fatigue become a core measurement when we do research in rheumatic diseases. I will explain at the moment our understanding of what may cause fatigue in patients with inflammatory arthritis, how we should assess fatigue, and last but not least, how to treat fatigue. So fatigue really only come into the prominence at the turn of the century, really. There's a global group called OMRAC, Outcome Measure for Rheumatic Diseases, and this is a global research effort to reach consensus of what we need to assess or measure in clinical research. And at the beginning of the century, the group started an initiative of trying to get patients' perspective and input into the research agenda. The aim is to develop research that meets the needs of our patient, to do what we call patient-centered research. Now, during that working group discussion, it became really clear that fatigue is a very important symptom in patients with inflammatory arthritis, including rheumatoid arthritis, just as Phil has shown for psoriatic arthritis. So the group agreed that fatigue should be measured in clinical trials and clinical studies. Now, at that time, although we reached an agreement that fatigue is important and we accepted that, we don't really understand what causes fatigue, how we should measure it, and how we should treat fatigue. So the working group actually developed a research agenda trying to address these questions, and the result of the working group are what I'm going to share with you during this webinar. So first of all, it is absolutely clear what patients tell us are correct. So this is a study showing that fatigue in patients with psoriatic arthritis significantly impact on their quality of life, regardless of what you want to measure, be it pain, mental health, the number of tender points, the physical functioning as measured by HAQ. So it is clear that it is a question that we must address and develop treatment for. Without going into great detail, it is also clear that fatigue is not caused by a single biologic effect. Fatigue is complex, and in inflammatory arthritis, there is good evidence that, in fact, fatigue can be caused by inflammation. It is associated with distress, and also has an impact on the psychosocial functioning of the individual. So how should we measure fatigue? For a long time, rheumatologists has borrowed questions that are used in other conditions like neurological conditions, chronic fatigue syndrome, multiple sclerosis, or cancer in order to measure fatigue in rheumatic diseases. None of these were developed specifically for patients with inflammatory arthritis. But recently in Bristol in the UK, they have developed a specific questionnaire that measures fatigue in patients with rheumatoid arthritis called the Bristol Rheumatoid Arthritis Fatigue Questionnaire. And this questionnaire has two versions. On the left is what we call the MDQ, a multi-dimensional questionnaire. And this questionnaire has 20 questions, and it covers many different aspects of fatigue, from the severity of the fatigue to the impact of fatigue, both on physical activity, emotional impact, as well as cognitive impact. But obviously, a 20 question questionnaire is quite long. So they have also generated a version of this questionnaire which only has 3 questions. And in the main, on the right, this BRAF VAS or numeric rating scale system would capture how severe the fatigue is. And depending on whether you want to use it for research or more detailed assessment, you can use either version of these questionnaires. And in fact, this questionnaire has been validated in patients with psoriatic arthritis, and it really showed very good performance in patients with psoriatic arthritis. So in patients with inflammatory arthritis, I think in the main, this questionnaire would be preferred nowadays than to the other fatigue assessment methods. So last but not least, we need to address how we want to treat fatigue in patients with inflammatory arthritis. So 2 large systematic review on intervention for fatigue in rheumatoid arthritis were led by the OMRAC fatigue group. One that focused on non-pharmacological treatment, the other on biologic intervention for fatigue. So if we look at biologic intervention for treating fatigue, the Cochrane review of systematic review really conclusively show what Phil has highlighted for biologic and pain. That is, the biologic treatment, be it TNF-based or non-TNF-based biologic treatment, were all able to reduce fatigue in patients with rheumatoid arthritis. The only thing to note is that whilst this intervention reduce fatigue in a significant manner, they don't restore full vitality or energy level. So it highlighted that while inflammation do drive a proportion of fatigue, there are elements of fatigue that are driven by non-inflammatory factors. And these leads to the notion that fatigue are multifactorial, and we need to evaluate why patients get fatigue and try to choose the best treatment for fatigue in that individual patients. Alternatively, we can adopt an attitude to say that nowadays the current treatment standard is to drive inflammation to the lowest possible level, so remission. So once you have achieved remission in the individual patient, then we can look at how to treat the residual fatigue. And in fact, in psoriatic arthritis, similar to what Phil has shown you, Similar effect has been shown for biologic agents on fatigue. So this is one biologic agent that has been used in the treatment of psoriasis and psoriatic arthritis. And in the randomized control trial, it certainly reduced fatigue in patients. And in fact, the mediation analysis that Phil mentioned before for pain also applies to reduction of fatigue in this study, suggesting that aside from reducing inflammation, perhaps biologic treatment have some direct effect on fatigue that we currently don't fully understand. For non-pharmacological treatment, two intervention has demonstrated a significant effect in reducing fatigue. One is physical activity. Two is psychosocial intervention. And by that, what these studies tend to assess is cognitive behavioral therapy. Now, recently, a large randomized control trial in the UK called RAV have actually asked psychologists to train the rheumatology team to deliver cognitive behavioral therapy at a group setting. And these patients all have their disease activity well controlled. So these are not individuals with active arthritis. And you can see that cognitive behavioral therapy was able to reduce the level of fatigue as measured by the breath impact scale. So I think we go back to this diagram. I think fatigue is complex. We are starting to understand that different factors drive fatigue in patients with inflammatory arthritis, and we need to capture it in clinical setting, trying to decipher what factors may be driving fatigue in the individual patients and try to tailor treatment according to the need of that patient. And with that, I'm going to pass this back to Phil and my sharing, and Phil will take you to the next agenda item on the webinar.
So now we are, by the way, starting to get questions, and we encourage you to put in more questions, and I'll come to those in a moment. But before doing so, I'd like to turn the stage over to our two patients that are here with us. And we're going to first hear from Minnie, who comes to us from North Carolina. Minnie has been a long-standing patient with psoriasis, psoriatic arthritis, and spondylitis, and has been a significant spokesperson for the Spondylitis Association of America. And then after that, Melissa will take the stage, who has been working a lot with the National Psoriasis Foundation and is currently a third-year medical student at Stanford. So Minnie, I want to take it away.
Thank you. Sorry about that.
Yeah.
I have had symptoms of psoriatic arthritis since birth, and unfortunately, it took me many years to get diagnosed. My mother mentioned the skin rashes that I had as an infant, and I remember those rashes as throughout my toddler and my young childhood years. They were on my arms, they were scaly. I had a lot of issues with rashes in my scalp, my neck, my arms, and there were times that I had issues with my fingers having significant pain in them, but there was not a real reason why. It was just difficult to ride a bike and be able to participate in a lot of, typical child's play like the average kid. As a teenager, around the age of 15, I started having hip pain. And unfortunately, that hip pain would go and come, and it just kind of had me thinking that maybe I was a hypochondriac, because it would happen sometimes when it was raining, cold weather, it would be triggered by different things, but there was never a real cause. I couldn't find out anything at any of the doctors. I was easily dismissed, of course, because I was young and I shouldn't have had arthritis, because the research wasn't there at that time. In my 20s, I started having that hip pain that would not go away. It was pretty consistent, and it interfered with my daily life. I walked with a limp, and then the back pain started, the relentless back pain that still has not gone away. And that went on for quite some time. So it took a while, but after several years of living with that, in my latter 30s, I was finally diagnosed with a form of spondylitis, and that helped me to get the treatments that I needed to be able to start feeling a little better. So I thought, but then my 40s rolled around and everything went haywire. I experienced the worst pain that I have ever experienced on my spondylitis journey. I had migraines that were severe for days and months on end. I had back pain. My feet were in pain. Everything was just not doing well. There were times when my ribs were in so much pain, it felt as if someone had a grip pliers, just grabbing each rib and just to the point, squeezing it just before breaking it. And that made it very difficult to sleep at night. Everything that I was taking at the time did not work for me to help me get in a better place on my journey. But fortunately, I did start getting better treatments. I found a better team of doctors that worked well together and did the things that I needed. One of the things that helped me was getting psychotherapy, the behavioral feedback therapy on my migraine journey to help me be able to cope with the pain. That helped me deal with my overall pain. And then having my blood work checked, I was able to get some of my inflammation markers checked and noticing things that were low, like vitamin D. I needed more fish oil. So taking supplements to help with some of the issues that come along have really helped me battle the fatigue. And I've gotten to a better place where I have a lot more energy because of that. Probably not like the average person, but definitely I'm at the point where I don't need a nap every single day. I'm not needing to sleep, just wanting to sleep every time I'm anywhere. So I feel like I've gotten to a better place just by being able to take my supplements, the combination of biologics, and just rest and learning how to live well with spondylitis. So that is my journey. And thank you.
Thank you, Minnie, very much. And we've already had a comment from one of the patients in the audience who says, wow, she's describing my whole life.
My goodness. I'm sorry about that for them. I really am.
Yeah. Melissa, take it away.
Well, hello, everyone. My name is Melissa Leeolou, and I'm thrilled to be speaking with you all today on topics that are just so important in my life. Like Minnie and many other people, my journey with psoriatic arthritis did begin with psoriasis. I was diagnosed with psoriasis as a baby. And when I was growing up, my psoriasis was already just debilitating and devastating. Psoriasis looks different for everyone, but for me, I had these thick red plaques just covering my whole body from head to toe, and the rash would crack open and bleed, which was just so painful. What I didn't know growing up is that psoriasis can be accompanied by arthritis. So when I was in my early 20s, I was living a very active lifestyle. I worked out probably every day. And whenever I experienced fatigue or pain, I just attributed it to whatever rigorous exercises I had done that day. And I think because of that, and because I had experienced pain and fatigue through my widespread skin symptoms, my just overall threshold for seeing a doctor was higher than it should have been. I finally went to a doctor after a really bad ankle injury that just didn't heal. I had essentially lost function over that joint. And through that, I was kind of forced to see doctors and ultimately talk about what was going on throughout my entire body. So ultimately, I was diagnosed with psoriatic arthritis about 25 years after my psoriasis diagnosis. Now, of course, we're here today to talk about this discussion on pain and fatigue in psoriatic arthritis. And when I think broadly about my disease management and my treatment goals, Pain has definitely been my focus from the start, but that's not to say that fatigue isn't a significant problem, because it really is. But for me, the general experience that I have with psoriatic arthritis is essentially the typical symptoms, probably very familiar to our listeners. And that's stiffness, pain, throbbing, tenderness in my joints, decreased range of motion. And another way to just describe it simply is that my joints feel like they get stuck in one place. It just hurts to move. Some days it feels almost impossible just to sit myself up and get out of bed in the morning. And other days it hurts to pick up my coffee mug or use my hands. But one reason why pain has been my focus is simply that it poses the largest barrier to my normal function. Meaning that for me, if I can't move my joints because of the pain, then no matter how deeply fatigued I am, I'm still going to be primarily concerned with my mobility and function, at least in that moment. But I think another important reason why pain has been my focus and my treatment goal thus far is that when we as patients describe our disease to doctors, it's really challenging to put the complete and total experience of disease into words. But pain feels more easy to understand because we've all felt pain in some way, and it's definitely a deviation from good or healthy, and it feels from a non-medical perspective like it might even be more treatable. On the other hand, when I'm not taking any medication, my fatigue is really problematic. I could probably sleep for more than 10 hours, wake up from that tired, and even if I push through the day doing my very best, my body is still ready to collapse by the afternoon. In those moments, I find it difficult to concentrate or just function, and it definitely impacts my life. But I also don't always feel comfortable talking about it. I have realized that I feel in some ways judged by people because whereas not everyone lives with pain every day, I think most people experience some version of fatigue pretty regularly. And this creates a lot of stigma around fatigue in a patient who says that they're tired all the time. And that creates kind of communication barriers between patient and provider. And as I continue to reflect on my experiences overall with psoriasis and psoriatic arthritis, I find myself much more comfortable talking about my skin symptoms because the rash is something that I can point to and I can show you and say, this tangible thing right here is the problem. But when I talk about psoriatic arthritis, I feel the need to justify or prove that I have these real symptoms, even when they can't necessarily be seen. And for that reason, I feel especially grateful to physician scientists like Dr. Mease and Dr. Choy for all of their work and research to learn about, understand, and find ways to assess pain and fatigue in rheumatology patients. But in order to do this, I will say, one of the complications is that patients and providers really need to communicate well. And certainly there are many barriers to a good working relationship with your doctor. Looking back to even my adolescent years as a teenager, had I known then more about psoriasis, maybe that it could potentially progress and I could develop psoriatic arthritis, I would have been much more invested in finding effective treatments and routinely having doctor appointments to check in or reevaluate not only my skin, but also my joints. I really felt like education at that time was missing for me. Now that I know about my diagnosis and I understand it in different ways, I continue to advocate for myself at doctor visits by speaking up about what I'm experiencing and how my symptoms are impacting my quality of life. But I'm a bit sorry to say that I still don't always put 100% of my faith into doctors alone. And I am so sorry for saying that. But like many patients, I feel like, I'm willing and have tried every possible remedy and treatment that I can get my hands on, no matter what it may be. And that often does not come from the doctor. So from diets and cleanses to herbal remedies, teas, and acupuncture, there is a very low threshold for me to try something new, even if it's the tiniest chance that it could help me. I will definitely do it. Ultimately, as I've come to understand my disease, the dangers of my disease progression, I have tried a variety of different medications, and not all have been effective for me, but I currently do take one that's helping a lot. And while going through different treatments has felt very frustrating and sometimes very disappointing, maybe even a little bit scary, I'm glad that I did keep trying to find something because the relief from pain and fatigue is just definitely worth it. With that said, I still continue to take a very broad approach to my health, a lot like what we heard about today. While diet isn't a treatment for my symptoms, I do my best to take care of myself as much as I can, with the hope that reducing inflammation from lifestyle changes and diet will supplement and support my medical treatments. With all of that said, I am so excited for new research and investigations that are interrogating the relationship between pain and fatigue, particularly in the context of joint disease. Because I think as we learn more about what's happening within our bodies in a scientific way, it'll be more targetable with treatments, and there will be more awareness about pain and fatigue in patients like me. Thank you. And back to you, Dr. Mease.
Well, thank you both. Both very eloquent and quite some journey that you both have had over your lifetime, really, in both cases. And many just isn't it a shame and a problem that it took so long for you to have people finally recognize what you had, and that was true, although to a lesser extent with Melissa. So we're getting questions in, and we're going to try to address all of them. Some of them are very specific for this particular program. Others are more, specific to a particular patient. But some that are coming in have to do with diet and supplements, and I want us to make a few comments about that. I should mention, though, in starting out our responses to those questions, in 2 sessions from now, the next one is on pharmacologic treatment update, but the one after that Elaine Husney from the Cleveland Clinic is going to be moderating in November will be on wellness and include discussions about diet and so forth and exercise. And so we encourage you all to participate in that one specifically. I can make just an introductory comment, which is that not even focusing on a specific type of diet per se or supplement per se, but there was a famous set of studies done in Naples, Italy, where in one group of patients, these were all in patients that were being started on what the class of medications called TNF inhibitors for their psoriatic arthritis. And one group of patients continued to eat as they normally would in Naples, Italy, which is a really good food, by the way. I don't know if any of you have been there. But the other group went on a very strict hypocaloric diet where they lost weight. And they lost about 10% of their body surface of their weight over the course of a 6-month period. And what they discovered was that the group that had this weight loss had a much more likely chance of achieving this state of minimal disease activity with their TNF inhibitor. They did much, much better. So when a patient asks me, Doc, is there something that I can do diet-wise? One of the simplest ones is simply being able to lose weight. And we know that there's a genetic proclivity in psoriasis and psoriatic arthritis for patients to have a greater risk of having obesity, not because of their dietary choices or because they're overeating, but just because the genetics kind of are pushing them there. And so they have to try harder in order to lose weight. But losing weight can lead to some improvement based on the experiments that have been done thus far. I'd like to turn back over, though, to Minnie and Melissa to hear some of your comments about Minnie, for example, you mentioned fish oils. And I know there is some science around showing that omega-3 fatty acid supplementation in our diets can lead to various improvements in heart disease, improvements in autoimmune disease. Any comments you want to make about that and how you approach that?
I definitely followed the advice of my physician on all of these things. And so I think that one of the things I noticed is I've had high cholesterol, which is hereditary, but I've seen a difference with that. It has also helped me with the autoimmune dry eye, which comes along with spondylitis or inflammatory arthritis in general. A lot of us have to deal with that, but my eye doctor has seen a difference with me taking it twice a day. So it's had benefits for me in different directions for overall health. I can tell a difference when I don't take it. I at first I'm like, what's the difference? And I take it sometimes. I'm like, I don't want to take this big pill, but there's a difference in the lab work. There's a difference in my dry eyes. There's just a difference when I don't take it. And so I know that I need it, and I have to take it just like I have to take a biologic. I need it in my system. So twice a day.
Yeah. Melissa, any comments?
Yes, I'm so grateful to engage in this conversation, because I think when I was a patient early on, I really felt like there was a dichotomy where there were physicians who would say this can be totally managed by diet. And then there were physicians who would say, you'll never get better without medication. And I've come to see that these ideas are really not mutually exclusive. And just as we heard in the presentation, patients do best when there's a multifactorial approach. And that's exactly the experience I've had in my own life. Before I tried medications, I went on very strict diets. I would read books, do my own research, Dr. Google at its best. And when the diets didn't work for me, I felt a real sense of shame. I felt like it was my fault, or that I could be doing something better. Over time, having conversations with my doctor and learning to incorporate both herbal remedies, supplements, diet, and exercise alongside my medication allows me to feel empowered as a patient, but also get the real help I need from a medication, because ultimately it's not fully in my control. And I was just born in a way where I have psoriatic arthritis.
Right. There's also a question from Kurt about vitamin D supplementation. Anybody want to address that? Ernest, do you have any comments about vitamin D?
Well, we know that there's a very recent trial of vitamin D supplementation in healthy individuals. And in that study, it shows that vitamin D supplementation reduced the risk of developing autoimmune disease in general. So I guess there's some enthusiasm about taking vitamin D supplement.
Do you know of any work related to people that already have established vitamin D and any amelioration of disease state?
So there's been the history about vitamin D insufficiency and immune disease and fibromyalgia there's a long history of this. And at the moment, it doesn't look like that if you have true insufficiency, the vitamin D supplementation can improve your symptom, but the effect is relatively small. So it always needs to be used in the context of effective anti-inflammatory treatment in the individual patients. So on its own, it has an effect, but not a huge effect.
That echoes what Melissa was commenting about, there not being mutually exclusive approaches. We've got a number of comments here which have to do both in the question portion, but also in the patient chat, which is a separate line, which basically says that people are searching. If I can summarize that, as people are commenting about having tried 3-4 different medications and now in search of a fourth that will, since they're failing on the third of the first three. I think this is something where we are dealing with this every single day in our practices, where patients are coming in who have had a great run for 1, 2, 3, 4 years with a medication, but now it's starting to flag. And I liken it to just the old Pony Express, where you'd have stations along the way with fresh horses, and you trade out your horses and go on out and deliver the mail. And so I think that this is one of the things that we know with autoimmune disease, that you need to keep trying different ones when you fail. But there was one comment here about somebody who's been on Humira since 2017, wondering how long can you take it? And the answer is you can take it as long as it's effective. We don't have any evidence that there's a limit. You know, in the old days when methotrexate was the only thing that we had available to us, and I can remember keeping tables where we were calculating how many milligrams of methotrexate the person was getting for their psoriasis and psoriatic arthritis. And after you got to a certain point, you're supposed to either stop the medication or at least get a liver biopsy to show that it wasn't harming the liver. Those days are, faded behind us. We don't do that anymore. But that's where the idea that there was a limit on how long you could take a med. But these days, with many of the newer medications, that's not necessary at all. There's also some questions that have to do with specific new medicines coming along. For example, someone has raised the question about the new drug bimekizumab. So bimekizumab is in the interleukin-17 family of medications. It inhibits IL-17A, similar to Cosentyx and Taltz, but it also inhibits IL-17F, which we think has a role in disease as well. And so we're very much eager to see that drug getting approved in the United States. It's already approved in certain parts of the world, and using it in our patients, along with the way in which we're using the other IL-17 inhibitors. I'm going to this is a personal one. One of my patients is saying, "Where the heck is my bow tie?" And so for most of you, you don't have any clue that the fact that for decades, I was part of my attire was wearing a bow tie. It started when I was at a boarding school as an adolescent, and we had to wear ties, and I started wearing bow ties then. But during the pandemic, Rose, I've been gotten a little bit more informal. So you're probably going, alas, that's too bad. But now I'm self-conscious. I'm thinking, oh, shoot, I wish I'd had it by my side because I could have whipped it on very quickly. Here's one. Ernest, I'll toss this one to you. Have there been any studies done with patients with AS who had COVID-19 and taking Cosentyx? And I can make a comment about that as well, but you start off.
Did you mean on the effect of fatigue?
No, just I think the concern was this is a person who is on Cosentyx, and so this isn't specific for pain or fatigue. It's just having to do with COVID-19 safety in the context of Cosentyx.
Oh, for safety. Oh, I think, Phil, I saw your paper on the topic using US data, and we actually have the same data in Wales that we have published. So actually, patients with psoriatic arthritis or ankylosing spondylitis don't have a greater risk of having more severe COVID. If anything, they tend to have a lower risk of more severe disease. The main reason is the patient with psoriatic arthritis and ankylosing spondylitis are on average much younger than the overall population in general. And in fact, none of the biologic treatment, be it TNF inhibitor, Cosentyx, IL-17 inhibitors, increase the risk of severe disease at all.
And that mirrors what we found. We've studied charts of about 9 million patients in the Providence Health Network that our hospital is part of. And out of those, about 300,000 patients with autoimmune disease. And what was found was just what Ernest said. It looks as though virtually most of our autoimmune diseases, but particularly psoriatic arthritis and ankylosing spondylitis, don't either lead to more likelihood of getting COVID-19 if you're exposed to it, any risk for severe outcomes like hospitalization or death, or mechanical ventilation. And the medicines that patients were using, including Cosentyx, did not increase any risk. Also, when patients are getting their various vaccinations and boosters with the IL-17 inhibitors like Cosentyx, we don't, or TNF inhibitors for that matter, we don't recommend any adjustment of treatment relative to the timing of the vaccination. It's fine to get the vaccination whenever. There are some guidances around methotrexate and the JAK inhibitor class, but we can get into that in more detail at another time. So let's see, I'm just scrolling down to see, there's lots of positive comments. Someone who made the, I think, comment that is only very realistic, which is, it's great to advise a patient about weight loss, but harder to achieve oftentimes. And we understand that. Here's a person who is trying to get on the right track with medication when we don't know which inflammation marker is flaring, and we have health insurances that don't seem to want to work for us. Isn't that the truth? I know that in the US, we have a lot of issues with insurance companies sort of guiding us down a certain path based on the cost of medications. And we don't have the full choice, it seems, unless we really fight for it, of which medication that we as clinicians want to use or you as patients want to take. In terms of knowing, getting on the right track, I think it's really a matter, as both Melissa and many have emphasized, being able to have open and transparent communication with your clinician, speaking to each of the various clinical domains, whether it's arthritis or skin disease or spine disease or nail disease, which is the most active part of your disease state. Labs and X-ray have something to do with evaluation, but really it's listening and taking a careful history and physical and knowing whether or not you're getting adequate benefit from your current treatment, and then figuring out, well, you've already been on 2 or 3 different anti-TNF medicines, so maybe it's time to switch to a different mechanism, like an IL-17 inhibitor or an IL-23 inhibitor or a JAK inhibitor. So these are all things that are going on in this sort of computer brain of your clinician as they're listening to you and balancing the issues of efficacy and safety in their minds, and then sharing those considerations with you and making a choice, and then handing that off to the person in the office that is in charge of getting approvals by the insurance company, which so I'm on a daily basis, I'm checking her hair to see how much hair she's pulled out the day before from sitting there on hold with insurance companies while waiting to talk to somebody to plead to get a particular medication for them. Oh boy. So Ernest, I'm going to have you start with this one, and then I'll make a comment. This is a patient, Pamela. I have AS and PsA. So it sounds like Minnie, where she has both PsA, but also very significant axial involvement. I have taken all nonsteroidals, disease-modifying drugs like methotrexate, steroids, and 3 biologics. Nothing works anymore, and my rheumatologist has dismissed me.
Oh,
because he has nothing else to give me. What do you have for us older patients who have tried everything? So you want to start off?
Well, I have to say, I feel a little bit sorry for the patient. And we have seen patients who are refractory to many biologic treatment, although I don't know exactly the detail of that. But increasing the new class of oral medication actually can work both for psoriatic arthritis and axial spondyloarthritis, like ankylosing spondylitis. I don't know, Phil, do you use the JAK inhibitors for these patients? Because that is my first thought. If you have failed several so-called biologic, then this targeted synthetic DMARD would be the one that I would definitely opt to go with.
Right, and with just 3 biologics having been tried, there are multiple others. So, for example, there are 5 TNF inhibitors. There are 2 currently available IL-17 inhibitors, 2 currently available IL-23 inhibitors. So sometimes, even though you've tried one medicine in a class, you don't necessarily assume that another medicine in the class won't work. So it seems to me that there are multiple options that that a rheumatologist may have to try, and so I wouldn't give up yet.
Yeah.
There's also another, but it sounds like you may need to go shopping for a new rheumatologist if you're having trouble with one that's sort of closing the door to and not patient to work with you on trying different things. There's also another person here who's tried even more medications of many classes and running out of options. So I'll mention a couple of things. First of all, and there is a study that's just starting in which 2 different biologics are being used together, an interleukin-23 inhibitor and a TNF inhibitor. That's Tremfya and Symphony are the 2 treatments that are being used as a combination, and then comparing them to the IL-23 inhibitor alone for treatment of psoriatic arthritis. So this is one of the first forays that I've seen by a pharmaceutical company to take the step, a courageous step, to look at combining two biologics. What's the reason why it's a courageous step? It's because you run the risk of having more adverse effects like infection, and then that is kind of tarring the overall good data that you have for either one alone. But I think it reflects the reality that there are many patients out there like you who have tried many things. And so now, like cancer physicians, we're starting to get more creative with combining and putting together 2 different medications. We do some of that, I will acknowledge, in the clinic off-label. There's really not an approval by the FDA for using 2 of these sophisticated medications together. And insurance companies sure don't like it because it's expensive. But if you use one that's relatively safe, has a very low infection rate, along with one that might be not quite as safe, we are starting to experiment with that sort of thing. So I think combinations, as well as some of the newer mechanisms of action that are being developed and are still in the research phase, I think there's more to look forward to in the future. Do you all want, Melissa or Minnie, do you want to make any comments about, hopefully neither of you is in this position yet, but I'm wondering if you have any comments for these individuals.
Sure, I'm happy to make a comment. It breaks my heart when I hear this. I have not been successful or not found success on every medication I've taken. And each time it feels devastating because, you go in with so much hope and maybe temporarily experience that relief. And so, when the disease flares and comes back, it's not only physically painful, but it's emotionally devastating. And so I think it's just so fantastic to engage in these conversations, know that patients are heard by our physicians and researchers, and that while there may not be a definitive answer now, there's so much research moving forward, new treatments coming out, we're understanding more about why this is happening. And I think that, we're already seeing how medicine is changing, and I have so much hope for the future and hope that we can share in that patient experience together.
Damien has asked about CBD. It was listed on one of my slides, and so I'll at least make a brief comment about it. So I live in Washington State. It was one of the first states to legalize marijuana, for example. So we have now 2 stores that are on every block: a Starbucks and a marijuana shop. And so there's a lot of my patients, their mothers, their fathers, and as a Christmas gift, their son or daughter gets them CBD jelly beans to eat, or salve to put on, or tincture to sniff. And so some of my patients swear by these. They don't get the high but they aren't bothered by the uncomfortable, out of control feeling of getting marijuana. But there is this a cannabinoid effect that can have a pain relieving effect. Interestingly, there was a study done in Denmark that was recently presented at one of our meetings. And because this had become legalized in Denmark recently, this group was interested in it. And so they did a placebo-controlled trial, giving an appropriate dose of a CBD compound and then placebo in treating patients with knee osteoarthritis and psoriatic arthritis. There's about equal number of patients in each group. And what they discovered was there was a significant treatment effect, significant reduction of pain, and it was equal in the placebo group and the CBD group. Okay, where's that placebo? I want some of that. And so it's if you're looking on the negative side, you'll say, well, didn't beat placebo, so not effective. On the positive side, it had a significant pain improvement effect. And so I'll leave it to you to make a decision on what to try. I don't think there's any harm at all in trying the various preparations that there are out there. Another person has commented about the fact that they have Crohn's along with their spondyloarthritis and psoriatic arthritis diagnosis. It sounds like this person has a real triple whammy going on with spine, peripheral disease, and gut disease as well. So that is a special situation. Many of the drugs that we are using for treatment of psoriatic arthritis or axial spondyloarthritis are effective for Crohn's disease. For example, the TNF inhibitor class, and now more recently, we're learning that the JAK inhibitor class can effectively treat both, and the interleukin-23 inhibitors can beneficially treat both. A problem with the interleukin-17 inhibitors is that they have the risk for flaring Crohn's disease, so there's a bit of a restriction there. But and it looks like she has combined a TNF with an IL-17 at one point. I hope you didn't get a flare of Crohn's, and an anti-TNF with one of the JAK inhibitors. So she's already, it looks like, in an experimental mode with her rheumatologist and gastroenterologist. And we do that a fair amount, where the gastroenterologist will prescribe one medication, like Entyvio, for example, for the gut, and we will prescribe another medicine like a TNF inhibitor or a JAK inhibitor for the musculoskeletal. And that sometimes we can get away with that, where there's 2 different clinicians that are ordering the 2 different medications. And I think that you're doing the right thing by trying some of these combinations. But boy, here's another person with the same issues that's just come in. And I think what you need to do is just keep trying. Just keep at it. Keep your situation in front of your rheumatologist and gastroenterologist to keep trying, because I think we potentially can get there, or at least for a while help you. Boy, there's a lot of activity in this this chat.
So do you think I can give a comment on this? Because in fact,
please do.
This is actually a project that I'm involved in at the moment because of that common strand in biology of how this inflammatory disease may be caused by similar biologic pathways. Actually, there's a European group that are working together to try to develop personalized medicine. And we are taking genetic and blood samples from these patients and try to identify what may be driving the different conditions in the same patients. And then we are putting it into a supercomputer to analyze the data to come up with a combination that may work. And we were trying to do what we call a basket trial. So we're actually going to put these patients into a single study and test whether these tests that we do can predict which combination of biologic medicine will work for them. So fingers crossed, we may have an answer for these patients in a few years.
I'm loving now the patient chat. Here's one. We have Starbucks on both sides of the street. Okay. And here's one person who's already commented in the question and answer area where she said that her rheumatologist is Dr. Ogdi at Penn. So that's great. She's a very good rheumatologist. There's a question here about low-dose naltrexone. Ernest, unless you have a comment about that, I'll just comment that this is something that some of our patients bring to us as a question about using naltrexone. Naltrexone is a medicine which is used for sort of countering the effect of opioids. It's used to salvage patients when they have a opioid overdose, and it has been used in low dose format for pain management as a kind of a safer opioid receptor affecting medication. And so when patient, we don't think perceive it as being problematic in terms of any side effect issues. There's not been great controlled research on it, but there are plenty of anecdotal comments that it can be helpful for patients. So we do have some patients that are using that approach. Ernest, do you have any, or Minnie or Melissa, do you all have any comments about that?
This exactly the same as your experience, really.
I would like to add that I am actually on low-dose naltrexone, and it is I would say it's a very good pain medication. To me, it is the best one that I've used. I prefer to stay away from the narcotics and the stronger meds, but I needed something to help me. And when I had my knee replacement last year, I was able to get through with ibuprofen and the naltrexone, the low-dose naltrexone. So I stand by it, and I'm glad that I discovered it. And it's also helped me lose a little weight.
All right. Okay. Well, this has been a very stimulating Q&A session and discussion section, I must admit. You all are just terrific out there. So we're approaching the end of our time. We really appreciate the fact that you all have stuck with us for all this time. We've had a record-breaking number of people attending and really are appreciative of that. It shows that there's a lot of interest in this topic area. I'm going to just quickly share my screen to show you what's coming up next. So here is some in this series that is coming forward. We've got some podcasts coming along. Release date September 29th for clinicians, and for patients September 27th. And I'm assuming through this same portal that you're coming to us today with to learn more about access to these. And then on October 5th and October 19th, respectively, there will be a patient and clinician-focused webinars on treatments. So this will be focused on a quick review of of the guidelines for treatment of spinal arthritis and psoriatic arthritis, and then drilling down into each of the kind of medications that we've been speaking some about tonight, but just in more detail about their efficacy as well as safety and strategies for their use. Atul Deodar, a rheumatologist from Portland, Oregon, is going to be moderating these sessions. I will be one of the participants, and a Harvard physician, Jorg Ehrman, will be participating as well, along with several patients. Then on November 3rd, there's going to be a patient-focused webinar entitled, Does Changing Health Behaviors Help Your Arthritis? Lifestyle, Myths, and Solutions. And I think it's going to be a terrific program led by Elaine Husney from the Cleveland Clinic, who's had a lot of interest and focus in this area. So we're totally pleased that you took the time to attend today's program. And on behalf of the sponsoring organizations, Spartan, GRAPPA, Spondylitis Association of America, National Psoriasis Foundation, and our funder, Pfizer, we are very appreciative of your attending. Thank you and good evening.